The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warrior, or plural warriors. We are here for the next episode of TMD Demystified, and I am Tony Urbanic. Today's title and topic is Treating TMD, TMJ with Competence. We're going to do a little slow walk through this. I will not take excessive amount of time, but again, I am doing this to make a point and to educate and to drive sanity into the treatment of TMD. Competence is what each of us as doctors should strive to attain in whatever we do as far as our profession. And hopefully you're competent at driving a car, and you're competent at taking care of your home, and competent at taking care of your children. Competence is a very important concept in life. You don't want to be incompetent, and we see examples of incompetence all over the place. I'm not going to dramatize any of that. I'll let you dramatize that for yourself. But as a licensed, trained dentist, or in my case, dentist and physician and academicianly trained doctor, competence has always been important in my world. So let's start out by defining what we're talking about. And again, this is going to be somewhat of a slow walk, logical, hopefully. If it's not logical, let me know. Again, I open up myself to criticism and comment, but I can't get anybody to criticize. All right, the definition of competence. What is this? If we're going to talk about competence, you have to, what is the definition of competence? So we're in agreement with what we're talking about, because what one person's definition of competence may not be what another person's definition of competence is. That happens all the time. That creates misunderstanding when you have disagreement on definitions of the words that you are using. Okay? All right, so we first have to go through this part. And by the way, I've spoken many times on the fact that when I do these episodes on TMD Demystified, I co-author a blog on the same topic, which is directed primarily to patients or public. And I use the same topic, which is directed to you, the practitioner and the professional. And I try to, obviously, a little different point of view, because the audience is different. I speak differently. I write a little differently when I'm trying to contact public and then when I try to communicate with my professional colleagues. But in this case, last Sunday evening, I wrote my usual 2-page blog entitled TMD, TMJ, Treating TMJ with Competence. And because I spent the time to sit down and think it through, I want to read just the first couple paragraphs of this to make it clear what the definition of competence is and the direction we'll be heading in the rest of this episode as it applies to treating TMJ, TMD. All right, so the definition of competence. This is directly out of Webster's. The ability to do something successfully or efficiently. Definition of competence: the ability to do something successfully or efficiently. The word competence is derived from two two Latin words. Number one, com, C-O-M, which means together. And number two, petre, P-E-T-R-E, a Latin verb, which means to strive, to aim toward. Therefore, competence means to be able to do something successfully or efficiently by striving together. Now, striving together could be striving together by a group or striving together by the attributes or resources of an individual, but striving together to do something successfully or efficiently. So that is what is meant by the word in the title, competence, treating TMD, TMJ with competence. Let me finish another paragraph or two, and then we'll go freely speak. But I'm going to put a link at the end of this episode, which you will be able to read this this blog that I wrote, 2-page blog, if you wish. In everyday use, competence addresses a person's ability to perform a duty or task in a predictable, confident, and successful manner. Practically speaking, it is critical that your surgeon, airline pilot, and attorney exhibit competence. I don't think any of us would disagree with that statement. If you are flying commercial or you need a surgeon or an attorney, you want to make sure that who you hire is competent. It is not very critical that your house painter, your lawn service, or local politician exhibit competence, although you certainly prefer they do. And we won't go into less competent necessarily services, but some services, you can give a little leeway in competence. Maybe not surprised of some incompetence in certain services or areas of life. So there are different levels of expectation when it comes to competence. As I go on reading in the blog, there is a difference in the levels of competence that people expect from others depending on how critical the service provided. So we've already discussed, if you're flying commercial, you want your pilot and co-pilot to be highly competent as you would your surgeon or attorney. Regarding the treatment of TMD, TMJ, temporomandibular joint disorder, what level of competence should a patient expect? How critical is TMD, TMJ in the overall experience of a patient? Is it as critical as one would expect from an airline pilot or a surgeon? Well, I would hope that you would agree that the level of importance is as critical to a patient, your patient, in treating TMD as it would be critical as when they were on a commercial airliner with a pilot or hired a surgeon or an attorney. So most patients who constantly experience the symptoms of this devastating disease would answer that the level of competence of the provider offering to relieve the symptoms is critical. Most patients, I would think that. The next question asked is, how does one build competence? Which we will talk about that extensively. And how does the competence between really competent people, airline pilot, surgeon, attorney, compare with dentists who treat TMD? Comparing the level of competence between those three examples and the level of a dentist treating TMD, there is no comparison. It has been proven in many different ways, which we'll discuss, that the level of competence doesn't compare. The dentist treating TMD, TMJ, are incompetent. Unfortunately, I don't take any pleasure in saying that. But if you have, whether you're right out of school or you've been practicing dentistry for 30 or 40 years, almost everyone, there are exceptions. There are exceptions who think they are competent, but most dentists by far know that those people who treat TMD, TMJ don't get the product. They can't provide the service. They don't get from A to B. If you got on an airplane expecting to go from Nashville to Denver and you didn't get there in 2.5 hours, you would probably think that there's something wrong and there's incompetence. Or if you were flying that airplane and that airplane crashed, you might think that the airline pilot was incompetent. Or if you needed the services of a surgeon who was to remove your appendix, and after the operation, the appendix was not removed. Or worse yet, the surgeon who was supposed to remove the appendix had to call in another surgeon to help them. Actually, that happened to me personally as a 5-year-old child. This is not a story. This is an example that happened to me. Incompetence. Back in 1952, I was diagnosed with a need to do an appendectomy as a 5-year-old, and the so-called surgeon who made the diagnosis and brought me to the operating table literally was unable to find my appendix and had to call in another more qualified, competent surgeon to finish the operation. That is a fact. That might be unbelievable to you. That happened in 1952 to me. Now, I remember very little of that example. I remember parts of it. I remember the operating table. I remember the mask going on my face to breathe me down with ether way back then. But I wasn't even planning on talking about that example, but that is an example of incompetence. All right. Unfortunately, I mean, I take no satisfaction in calling out the fact that our profession does not treat TMD successfully. The remaining of this blog, I'll put a link to at the end of the episode here. So, how do we develop competence? How do you develop competence in any field? Well, first you have to study. You have to get some information. I'm very much familiarity with the surgeons. I am one. Although I no longer practice surgery, I am a surgeon. And I have tremendous amount of experience in the aviation industry, although I do not have a commercial rating. I'm a multi-engine rated pilot and actually did flight physicals for 20 years for airline pilots and private pilots so that they could get the other certificates. They had to have a medical certificate depending on what level of training they were in, what they're accomplishing, either every 6 months or every 2 to 3 years. And I did those flight physicals among many other aspects of aviation. So I'm very familiar with those two areas. I feel confident to speak on them. So regarding airline pilots, you start out with the books and you read the regulations and you basically read or study the theory and the mechanics of flight, of weather, of avionics, of the air traffic system, and many other aspects of aviation and then you get in an airplane and you then learn the mechanics of flying the airplane. And more importantly, you drill it and you drill it and you drill it and you drill it until you are ready to take an exam at certain levels, your private pilot, your instrument rating, your multi-engine rating, your commercial rating, your ATP, airline transport rating. And at that point, you have exams all the way along and recurrent exams to make sure that you don't lose the edge. And believe me, I can assure you, if you have anxiety about flying commercial aircraft, with extremely few exceptions, there are exceptions to every rule, but with extremely few exceptions, airline pilots are competent flying airliners. Some people squeak through the cracks, but they are monitored constantly as to whether they're competent in all aspects of aviation. And it gets pretty complicated. I mean, it is a complicated field, as is surgery. Now, the same thing applies to surgeons. As a surgeon, finishing dental school and coming to Vanderbilt and starting a further academic degree, MD, PhD, internship, residency in oral and maxillofacial surgery. It was a matter of reading the books, having more information, just like you did in dental school, and then stepping up to an operating table and beginning to apply the theory and the mechanics, literally the mechanics of surgery, and having constant monitoring that it was done correctly to the point where you were examined. And whether it was an examination outside the operating room, I remember my examination in anesthesiologist, because as an oral maxillofacial surgeon, you take extensive training in the operating rooms doing multiple cases of general anesthesia before you're ever going to be qualified to be a oral and maxillofacial surgeon and eventually get your boards. So there's a certain amount of examination at every level. In this case, breaking out anesthesia is an independent examination, an independent series of events. And then it gets into surgery and diagnosis and each type of surgery. And each type of those surgeries are reviewed and qualified. And then eventually you have the opportunity to take your boards, at which point you are really grilled overall in each and every kind of service that you may be applying as an oral and maxillofacial surgeon. So when you finish that process, believe me, you know whether or not you're competent or not. And some people don't make it. Some people can't pass their boards, unfortunately. But those that do pass their boards and go through the examination process, not only do you get to wear a star on your forehead, but you feel very competent because you have been examined in the areas. Now, this does not apply to TMD, TMJ. It never has. And this is a devastating problem, this thing we call TMJ. All the patients call it. Most of the doctors now call it TMJ. It's a devastating disease. It ruins lives, some faster than others, some more devastating than others. It's a progressive disease, so once it starts, you only know it's going to get worse. It never gets better. It does vary in cycles. So that's one of the problems. It comes and goes, but as time goes on, it hurts more, stays longer, hurts more, stays longer, hurts more, stays longer. And so whether the process takes 6 weeks or 40 years, it's always cyclical. It always gets worse. And as time goes on, you add symptoms. And some of the symptoms, in fact, each and every symptom is a devastating symptom if it progresses to the point where the patient can't stand the symptom anymore. And to remind you, the symptoms of TMD are frequent or recurring headaches, most often misdiagnosed as migraines. We've talked about that extensively. Doctors who study migraines admit they don't know what causes migraines, but we've seen thousands and thousands of patients who have the diagnosis of migraines that don't have migraines, they have TMD pain. So frequent or recurring headaches, frequent or recurring earaches, ear pain, frequent or recurring neck and back pain, upper back pain, arm, hand, finger tingling and numbness, tinnitus, ringing in the ears, fullness in the ears, like you're literally hearing loss in one or both ears, subjective hearing loss, serious vertigo. I've seen so many, each of these symptoms can come across as serious symptoms that doesn't allow people to drive, doesn't allow people to miss time at work. They can't work. Multiple women have come in and say, I'm a bad mother. My constant headaches drive me to insanity. I've had 3 ladies tell me that they have, one of them on video, that they have contemplated suicide. How bad can symptoms get when you're thinking about killing yourself because you have this chronic symptom that nobody can help you with? I'm just talking the logic, the obvious things that have been in our face to confront this thing. It is bewildering to me now that I have experienced the difference and actually developed a system, a device and protocol that solves the problem, why and how this problem has not been solved much, much, much earlier. And I've spoken on that, and I have an opinion. Now I'm going to speak an opinion of why that happened. But the point being, again, competence. And I'll prove the incompetence. Half the dentists use a night guard, and no one has ever argued with me on this point. Half the dentists in the United States, if they think their patient has symptoms of TMD or made the diagnosis or told that they have the diagnosis of TMD, will give the patient a night guard and tell them it's their treatment for TMD. And the other 49.99% don't want anything to do with TMD because they know nothing works, because they know the level of incompetence that is out there treating the disease. And the 50% that do give a night guard, most of them know, not all, but most of them know the night guard's not going to help. But they give the patient the night guard to get them out of their office and hope they don't come back. And I have had this discussion with this exact same point in person with hundreds of other dentists, some of them I know personally, and a lot of them I don't know personally. And I have never, ever had a doctor argue with me or try to tell me what I just said is not true. Because why do they not want to argue? Why do they not want to say it's true? Because they see it for themselves like I have. Half the dentists don't want anything to do with TMD, and half the dentists use a night guard and hope the patient never comes back. I can't think of anything that could be described as more incompetent in an area of treatment of which the patients expect competence and the patients expect solutions. So treating TMD with competence is very important. Now, not as a commercial, but the truth is that this joint is no different than any other joint in the body. That was the beginning of the big discovery. You were taught in dental school, this joint is different, it's unique, it's so complicated, nobody can figure it out, which was the justification for not teaching you or doing further research to learn about a solution for TMD. That was the beginning. That was the big out point. That was the big lie. This joint is not different. It operates like hips, knees, and elbows. The same physiologic processes occur. So, and then it began to come into view that inflammation drove all the symptoms. It was not a problem with myofascial pain dysfunction syndrome. And I actually pulled out the original article. I've talked about it before, and I decided I need to find and pull out this article and read it again, because I have read it in the past, on the etiology of the pain dysfunction syndrome, which was originated by one of my oromaxillofacial colleagues way back in 1969, Dr. Daniel Laskin from University of Illinois, the JADA, volume 79, issue 1, pages 147 to 153, July 1969. And if you are a member of the ADA, you can pull up this article in the library. They have it in the ADA library, access to it. So if you want to read this, this is, although he was well-intentioned and he is an icon, I admit, an icon in the field of oral and maxillofacial surgery, he missed the point in his article, which was the beginning of what we now call the myofascial pain dysfunction syndrome theory. And it is a theory, but the theory doesn't hold water. And it all began in 1969, which is like when I started dental school. 1969 was my first year in dental school. I don't know if the timing was really good or timing was really bad, but this is a theory and it doesn't hold water. Again, I don't get any benefit by criticizing past. I think people are well-intentioned, but they can't follow a line. They can't follow logic. So what we need to do is confront this problem directly. It's just a matter of confronting it. It's a matter of, first you have to admit that the competence has not been there. If you have a group of doctors who think they're competent and are not, like the doctor who told my parents I needed an appendectomy, when actually, as it turns out, I didn't have a hot appendix. I had constipation as a 5-year-old. That's why he couldn't find the hot appendix. It wasn't swollen, it wasn't big, it was extremely small in a 5-year-old, and he had to bring in a separate doctor who was competent enough. So we have to confront the problem that there is tremendous incompetence out there. And I must add the group of what I call, and I stand by it, and many other doctors use the term, the TMD gurus, who use smoke and mirrors. There's a lot of that going on. Fortunately, only by a few doctors, dentists, but they use, at very best, I give them credit for trying to treat symptoms, but they don't address the cause, which is inflammation within the temporomandibular joint. If you only treat symptoms, that will only be temporary, because the symptoms are great. There are a great number of symptoms and they move around. And if you're only focusing on a symptom, then you're going to miss the rest of it because you're not focused on the cause, which is inflammation within the temporomandibular joint, chronic inflammation. So you have tremendous incompetence. You have incompetence by TMD gurus who think they know, and they focus on articles like this, which is truly a theory, which does not hold water, based on science, even though the author was well-known, well-intentioned, and it's in print. But because it's in print doesn't make it true, for sure. There's a lot of things in print that are not true. There's a lot of people who have been, millions of people who have been treated for migraine headaches that don't have migraine headaches. They have bad TMJ headaches, which is driven by chronic inflammation within the temporomandibular joint, which I've explained that concept and how the autonomic nervous system is driven by inflammation to create muscles to get tight. And when muscles get tight, it pulls on the bone, and where the nociceptors are attached in the periosteum, it creates pain. Spoken of many times in many different episodes. So with that being said, I ask the viewers and listeners to confront the problem with me. Let's be honest about this. We're not going to really solve this problem unless we confront it, get honest about it, address it to the patients that need it. You know, if you have any kind of size of a dental practice, you will be seeing patients with TMD symptoms. And some of them will come in and tell you they're seeing you because they think they have TMJ because they were told by their physician who finally diagnosed the problem rather than calling it migraine headaches or ear infections. And the physician's answer is go see your dentist. That is a fact. And then they come to your office and they say, my physician said I need to see you because I have jaw joint problems. I have TMJ, TMD. And then it's a matter of, are you competent in treating this? So we have figured out a process, a method, a device and protocol that is very competent, backed up by a independent university study here in Middle Tennessee, based on 3,000 successfully treated patients. 3,000, that's what the study is based on. We now have well over 4,000, probably approaching 5,000 successfully treated patients using a simple device that unloads the temporomandibular joint long enough to make the inflammation go away, diminish, and then use it consistently over a period of time to keep the symptoms down by decreasing the chronic inflammation by unloading the joint. It's a protocol and a device, a tool. And by using that, it solves the problem. But to use it, you have to take a course. You have to understand how it works. You actually take a little test. Nowhere near not even close to the level of testing that an airline pilot or a surgeon would have to go through to finally get his certificate so he could go into an operating room and perform whatever surgery he's been trained to do. General surgery, ENT surgery, oral and maxillofacial surgery. Little test and follow-up, and then a tremendous amount of information that can be added on to pick up all the nuances of what you can expect to how to treat a patient and why, and dealing with patients with this problem, and quit calling these patients crazy because they're not crazy. They're crazy with pain. I've spoken on these in many different episodes, but I wanted to bring this all together around this area of competence. And the first thing we have to do is admit that on the topic of TMD, TMJ, the comparison of competence does not compare to other areas that demand competence. And it should be agreed upon that patients coming to a doctor with this problem demand competence. They deserve competence. You as a doctor, it is appropriate that you become competent at treating this problem. Thank you very much for your attention. I hope I made the point. I hope I've stimulated you. I hope I've stimulated you in a positive way. But if you've been stimulated in a negative way, I am open for criticism. I am open for discussion. I would be happy to discuss any part of this with anyone who'd like to contact me. I can be contacted at tony@tmjservices.net. If you'd like to learn more about becoming competent, that can be done at www.urbanictmj.com. I look forward to hearing from you. I look forward to the next time I can speak with you on the next topic. I am Tony Urbanic, and this is TMD Demystified.